Dr. Kanth is a gastroenterologist who received her medical degree from Kasturba Medical College in India. After obtaining her graduate training in the UK, she moved to the United States and completed her internal medicine residency at the University of Connecticut. From there, she went to Utah, where she completed a GI fellowship and a Master of Science in Clinical Investigation from the University of Utah, after which she was recruited to join the faculty, where she is an associate professor in the Division of Gastroenterology. Dr. Kanth leads a hereditary GI cancer clinic at the Huntsman Cancer Institute in Utah, and her focus has been familial and inherited GI cancer and GI cancer risks. Her research interests include clinical and translational work in serrated colon polyps, colon cancer prevention, and high risk for familial colon cancer. She is a recipient of many awards and honors and grants, has published significantly in the field of gastroenterology and GI cancers. And we look forward to hearing more about your work and educating us and updating us on serrated colon polyps and colon cancer prevention. Please join me in welcoming Dr. Kanth.
Thank you, Dr. Haddad, so much for that kind introduction. My talk today is on colon polyps, colon cancer, and genetics. And I work as a gastroenterologist, but my clinical research work is what you're looking on the slide. I work in the area of colon cancer prevention. I also run this high-risk GI cancer clinic, and I talk about this because this is a unique clinic where I have a genetic counselor in my clinic, and we see patients with many syndromes, many other polyposis conditions where they're followed on a regular basis. And that's very rewarding to follow these patients long-term. The talk today is really geared towards internal medicine doctors and primary care doctors. My goal always is, hopefully you can get something from this talk and apply into your clinical practice. And this is really based at primary care level, which is, I would say, foundation for colon cancer prevention. We cannot really work or function without a primary care doctors, especially in this field. So the things we are going to talk today about is some numbers, colon cancer statistics. What are colon polyps? How are they different? And how do they turn into colon cancer? How do we prevent and surveil for this colon cancer? And there is a lot now being seen in the recent rise of early onset, young onset colon cancer. So I'll talk a few slides on that. And then I'll end the talk with the role of genetics. So where does genetics or how much genetics is playing a role in this disease? So let's talk about numbers. So where are we? Colon cancer still has a high disease burden. It's second leading cause of cancer-related deaths in the US, third most common cancer in both men and women. We know about this. American Cancer Society comes up with numbers every year, expected numbers of new cases, expected numbers of deaths that's going to happen from any cancer. Now, this is estimated 147,000 or so this year for colon cancer, 53,000 deaths from colon cancer. This number changes every year as the population grows, but with COVID this year, we are a little worried. This number will be more than what we expect for next couple of years, as patients are hesitant. Some patients are hesitant to get this screening. So we still have to put the word out that, talk to your physician and do not delay your screening. That is so important. But this number might look different. So when we talk about colon cancer risk, what is our risk? So if we don't have family history of colon cancer, if we don't have a known genetic mutation, a known cause of colon cancer, all of us have 4 to 5% risk of colon cancer in the US. The best scenario is we find cancer in the colon, remove it, and treat it. 5-year survival is really good, 90%, much better than some other cancers. And we can all technically live without our colon. The sad part is only around 39% of cases are diagnosed when they're still in colon. So that's the area we still need much work on. And as the cancer grows beyond colon, goes to other parts of the body, 5-year survival can be very bad, as low as 12%. So what's happening with incidence and mortality in the US? And I want to show you this graph. I'm going to get my pointer out here. It's easier that way. So incidence, if you see the graph here, around 95 or 2000, the incidence started dropping down. And so is the mortality. You can see 1990 to 2000. So it is on a downward trend. Now, part of it, or 50% I would say, or around that, is prevention, is screening, is what we have applied in this country. Prevention and screening has surely played a role, but not all. Some of it actually comes from maybe things like smoking cessation. Maybe even things like we are thinking about lifestyle changes. We are not there yet. Obesity is still a big problem, but we are at least thinking. So smoking cessation has helped, but a big chunk of this decline is from prevention tools we have applied or we are applying. But what's happening worldwide? If you look at worldwide, that's US data. That's not the case everywhere. If you look at this, I wanted to show you this because this also tells you how prevention and screening works. Red is US, same graph as before, is going down. But there's some other countries from Europe which are not. The topmost is Slovakia, then you have Netherlands, here is UK. It's still going up, or at least the data is that colon cancer incidence rising. They also have high incidence of colon cancer. Korea, there has been a steep rise. So not all countries have low or the downward slope. Also in countries which don't have high incidence of colon cancer. So yellow is Thailand and green is India. We don't have great data from these places yet. We don't have big registries. But what we are noticing that colon cancer, even with low incidence, is rising in these countries. So we don't have prevention strategy in these places. But in 10 years, 20 years, 30 years, we don't know what's going to happen. So saying that it's a worldwide issue, in a lot of places, the incidents are still on the higher side or rising. So when we think about colon cancer, what really makes it? And I like to show this pie. This is from Dr. Randall Bird, who was at University of Utah here at Huntsman Cancer Institute. And he did a lot of work in FAP world. And I like this pie because it tells you what is it made of. So 70% of all colon cancer is sporadic. We have no idea what's causing it. No idea in the sense that it could be lifestyle, it could be genes which we don't know of. But 70% of colon cancer, we don't know what causes it. 20 to 30%, 10 to 30% is the familial. So that basically means someone in your family has colon cancer. Mostly a first-degree relative, but that's the familial part. But if I do a gene mutation test, we won't find anything. At least so far, we haven't found anything. So that's the cluster familial. Then you have around 6 to 10% is the genetics of colon cancer, that we have an identified gene germline variant we can associate and say this is causing the colon cancer in this patient or in the family. The biggest chunk is Lymph Syndrome. 3% of all colon cancer comes from this. But then there are lots of other polyposis, rare conditions. FAP, familial adenomatous polyposis, is only 1% of all colon cancer, but it's very aggressive. When you see this, you can never forget it. It's very dramatic, a presentation with thousands of polyps. And if we don't surveil this colon, leave the colon alone, not surveilled, by age 39, 100% risk of getting colon cancer. So that's why even with 1% is such a significant part of GI world. Hematomatous polyposis, and there's some other polyposis, serrated polyposis syndrome, and other polyposis which constitute this section of genetics. So I'm going to talk about sporadic, and as a gastroenterologist, a chunk of my work is doing endoscopy. I do a lot of high-risk endoscopy, but I do also general GI endoscopy, and we are looking for colon cancer. That's the goal. Early stage is the best scenario, but majority of our work is really looking at polyps and removing them. So before we understand colon cancer, we must understand colon polyps, because in your primary cares, in your internal medicine, when you send patients you'll get reports back from pathologists, and then the letter from GI doctor saying, these are the polyps, and this is how we're going to follow them. And they're different. Broadly divided into benign and preneoplastic. So hyperplastic polyps, mostly rectum, small ones, even if we don't remove them, they don't do anything. Mostly in the rectum hyperplastic, they just stay there, doesn't turn into cancer. Preneoplastic is now divided into adenomatous polyps. 70% of all colon cancer comes from this. Roughly 20 to 30% of colon cancer is now understood to come from these lesions called sessile serrated adenoma polyps. The new term is sessile serrated lesion, last year changed. I write new edition because when I was a medical student, we did not know what this was. We did not know this till like 15 years ago or so, or that when we started recognizing 15 to 20 years ago, and now WHO placed this in the section of preneoplastic. So these are preneoplastic lesions. They also look different. And we should all be familiar with this because you're going to see more and more reports of serrated lesion in the pathology. Adenoma polyps, adenomatous polyps look like polyps. They sometimes have a stalk, but they really could be visible. Serrated lesions are flat. They usually have a mucus cap, and the margins are kind of vague. So these are difficult polyps for an endoscopist. If the prep is not good, if I'm not doing a great job, if I'm not able to see the colon very well, I'm going to miss these polyps. And that's a problem in the world of serrated lesion. The world of serrated lesion is now divided into three big parts. Hyperplastic polyp, which I said are benign, are in the classification of serrated colon polyp. It's further divided into what you see here, MVHP, goblet cell, mucin poor. These are not used clinically. Sometimes you can see this, but it's not really used clinically for research purposes. And there's some debate with MVHP question mark. They have lesions which can turn into cancer or not, but hyperplastic polyps are benign. Sessile serrated adenoma polyps, now called SSLs, majority of them don't have dysplasia, but some will have, and that's uncommon. And then you have the third one, which is traditional serrated adenoma, which truly doesn't look like flat. It really looks like villus and mostly found in the left colon, and they're very rare. You will find some reports with TSA, but really rare. If you get a report of adenomatous polyps, by default, they have low-grade dysplasia. That's not the case with SSL, and that's the problem with these lesions. Most of these lesions do not have dysplasia, and that's why there's a big trouble in even understanding what serrated lesions are, and there's a problem in the world of pathology, how to differentiate SSLs with like high confidence compared to hyperplastic polyps, because most SSL will not have dysplasia. So classically, how do they look? If you look at the right side, hyperplastic polyps, tubular, long, and they're called serrated because they have sawtooth appearance, and it's easy to recognize that. Sessile serrated lesion classically will have basal cell crypts, which are dilated, and they, a lot of time, will herniate into lamina propria. So this is called boot-shaped herniation. This is the classic appearance. The problem is it's not classic all the time. There's a huge overlap between these two lesions. And a lot of times there's only one crypt or two crypts, and it gets tricky and may not have dysplasia. So this is an area still trying to understand how to recognize these two conditions better so that we can follow them better, because hyperplastic polyp patients may come back in 10 years, serrated lesion, sessile lesion can come back in 3 years and 5 years. So this is a big clinical problem. So there is a high inter-observer, intra-observer variability. How do they look? I showed you they can look different, but most of the time they have this flat appearance. This is traditional serrated adenoma. They're mostly found in the right colon, predominantly, and they're also attributed that they're part of interval colon cancer. That basically means patient gets a colonoscopy, but gets colon cancer within 6 months to 60 months, within 5 years, which shouldn't happen, but patient got colon cancer. That's called missed colon cancer, or interval colon cancer. That serrated lesion has been suggested as causing this. Part of it is, if I can't see the lesion on colonoscopy, I'm going to miss them. Or if I can't see the margins, I'm not removing them very well. So that could be part of the missed polyp and missed cancer. The other part is biology. The biology of serrated lesions are different. They are considered high risk, much higher risk if they have dysplasia compared to a regular tubular adenomas. And I'll show you that in a couple of slides. I wanted to show you how difficult it is or can be for an endoscopist. This is my 21-year-old patient with Lymph syndrome. And what I wanted to show you here, the first one is a white light colonoscopy. And if I don't put the arrows, you can barely see the polyp. And I could barely see the polyp when I was doing her scope. The clue I got was there was some mucus scab or stool sticking to this area, which was not going away easily. And that gave me kind of a clue there's something there. And then we use different modalities. I use NBI. This is an imaging technique you can use on your scope. And that helped me highlight a little bit, not completely. I use blue dye, or called chromoendoscopy, in all my Lynch patients. So I was using that, and I was trying to use that in such tricky scenario. And that helped me see the margins. So basically saying that serrated lesions can be very difficult to find. And this turned out to be a 3-centimeter lesion in here. So you have to really stress on a good prep and a good exam to find these lesions and remove these lesions, to make sure you've removed it completely. So this is a big problem. I talked about biology of SSL. This is a study, a neat study on this, 2,000 colon cancer compared with many controls. And what they wanted to look at, what was the 10-year risk of different polyp types? And serrated lesions, sessile serrated lesions with dysplasia, had higher risk than conventional adenomas. And that's what we think, that if SSAPs with dysplasia actually should be considered as advanced lesion because of this, that a polyp, which turns into adenoma and then cancer, can take maybe 10 years or sometimes even 15 years to turn into cancer. A serrated lesion with dysplasia, the biology is probably quicker. Maybe it's in 5 years, maybe it's in 7 years, and that's why they need to be followed aggressively. So what do we do as endoscopists when we get the report? Now, this world has recently changed for us. This is a new guideline, how we follow polyps. And what I wanted to highlight, the biggest change, and you don't have to worry about it, it's a busy slide, just to show you, we base it on adenomas and how many polyps, size, and all that. But what's the biggest change is smaller polyps, 1 to 2 smaller adenomas, can now be surveilled in 7 to 10 years, almost as normal colonoscopy. So that has been the biggest change in the world of how do we follow these polyps. So these are considered now less riskier than how we used to think before. Sessile serrated lesions are still considered at par as adenomas, and if they are high grade, if they have dysplasia, then they are considered advanced polyps. So let's talk about pathways. How do these polyps turn into cancer? There are 3 major pathways, and I showed you 70 to 80% comes from adenomatous polyps, which is your typical chromosomal instability pathway or adenoma carcinoma pathway. APC KRAS driven, takes 10 to 15 years. Serrated pathway is not APC driven. It's really BRAF gene driving it. That's what we know so far. Or CPG island methylation, one of the other mechanisms it goes through. Or one of the other way is called MLH1, which is a mismatch repair gene. When that gets hypermethylated, so methylation of that gene could be playing a role. But you see a lot of question marks still there. We don't know if certain hyperplastic polyps turn into serrated lesions, SSLs, or their normal mucosa just changes into SSLs. So still an evolving area. The third pathway is the Lynch syndrome pathway, which is these cancers goes through mismatch repair genes, which are defective, and goes through microsatellite instability. Also certain question mark here, because there's a thought that all polyps may not be turning into cancer in Lynch. It's possible that the cellular level at the cell, the tissue changes into cancer so dramatically that we can't even find on colonoscopy. So that's another thought in the Lynch world. The serrated pathway is still evolving, but I wanted to show you that it's a little bit more complex. So BRAF is the main driver here, and you don't have to worry about everything written here, but what I wanted to show you that KRAS can also play a role, and mostly in traditional serrated adenoma. Even though this is APC carcinoma pathway, it can take that route, and it could be SIMPI or SIMFLO, can be microsatellite unstable or stable. So it's a combination of all kind of things we are thinking at this point, still with a lot of question mark, and we still don't know what serrated cancer means. we don't get a diagnosis of serrated cancer from the pathologist because we don't know what it really means, how to treat this differently, or do we have to treat this differently. I wanted to mention a classification. This is called consensus molecular subtype classification, mostly used for research or described in research world, but the potential is that this could be used in future for treatment intervention. So you should be aware of this. This is based on gene expression profile. So a bunch of colon cancer data sets, including the biggest one, the Cancer Genome Atlas was included. So 4,000 plus patients. And they looked at what are the various genes associated or are found in these cancer and what's the histology, but also survival outcomes. And then based on this, this was divided into 4 types. MSI high immune is your Lynch. So CMS1 is more Lynch-like, more serrated pathway. CMS2 has the best survival. CMS3 is metabolic. CMS4 is mesenchymal, but worse survival. So not something you will see in your day-to-day practice, but this is a classification now being used in a lot of research world to classify lesions and understand, and that could we use this in treatment intervention. So how do we prevent colon cancer? This really comes down to the internal medicine primary care level and for all of us. It's a tumor, it's a cancer we can prevent by early detection and treatment. So we start with who should get screened, average risk. So all of us who don't have a family history, who don't have a known genetic mutation, 4 to 5% risk, who gets screened. So U.S. Preventive Services Task Force is the body which designs it along with many other bodies. Recommendation is 50 to age 75, all adults get screened. After age 85, screening is not recommended. But that between that, 76 to 85 is the group you should really focus on now. Why? Because if they're healthy, if they don't have many health issues, if they're going to live till 100, if they have 10 years life expectancy, if they have never been screened, especially, that is the group you should definitely be screening. I have patients who are 77 years old, 76 years old, never been screened, very healthy. They should still be sent for screening. And you can choose any modality, but they should be considered for screening. So that's a group which is, you can talk to your, it's a patient-doctor level talk and decide, does it really work for you? I usually say, if I do a colonoscopy, you're healthy enough, if there is a complication, if you can get surgery for that complication, and if you have 10 years life left, you should definitely get screening. This is not for non-average risk, so patients with family history, hereditary colon cancer, advanced colon polyps in family, inflammatory bowel disease, they do not follow this route. They have a different recommendation, start early or even much more closer intervals. So this is only for average risk. So what changed in 2018? American Cancer Society said 50 is not the number we should start. We should start at age 45. Now, this is a qualified recommendation, not strong. Basically means it's based on modeling studies. We don't have long-term data, of course. We don't have great trials or case control, good cohort studies, but this is based on some solid data that there's rise in young onset cancer. One thing to keep in mind, if we drop 50 to 45, is going to add 22 million people for screening. So that's a big resource and logistic issue. Like how do we get, when we are not even screening 50 and above as we should be, like completely screening them. So this is a problem of implementing that. But this is based on some good data. And we have seen in recently, it's been a challenge that there has been a rise between age 20 to 50 in colon cancer. This data was showed 1991 to 2004, there's been 50% increase in colon cancer and also 10% or so increase in mortality. The interesting part about young or early onset cancer, they're mostly left-sided, predominantly. They're rectal cancer. They're also aggressive. They're aggressive cancers. They're found late, and we really don't know what's driving it. But the projection is this will keep happening. The cancer, what we know about after age 50, is going to go down, and a lot of it is because of prevention screening, and is going to keep rising for young onset. Now, 10% of all colon cancer is coming from this. So young onset, less than age 50, constitute that 10% of all colon cancer. Like I mentioned, they're left-sided, they're aggressive. And if we do genetic testing, 20% of them will have germline variants. So we can find the germline variant cause in 20% of this young onset. but 80% are still sporadic. We have no idea what's driving this, honestly. Like, we haven't really found one good thing or a combination. Lots of these patients are just young, healthy patients who are getting these cancers. So we don't understand this very well. But 20% is the cohort we can still find early, maybe even early, and surveil them early. So where are we in 2020? American Cancer Society is saying age 45, that's what they have been recommending. Multi-society task forces are GI societies, that recommends age 50 still. Age 45 is for any African American. So this is a strong recommendation. For African American, you should start screening at age 45. National Comprehensive Cancer Network, which reviews their guidelines every year and kind of went back and forth in discussion, but age 50 is what they're sticking to at this point with this year guideline. American College of Physicians came out last year, still says age 50. U.S. Preventive Services Task Force has not updated yet. The recommendation are from 2016, and they are in the process to change this. So we'll see if they change it. This will be a big change because this is the main body where most of the payers use this. So this will be interesting to, of course, watch this year or maybe next year. So in your clinic, in primary care clinic, how do you approach young cohort? How do we approach and find these patients so that we don't miss or find these lesions early on? They're aggressive. They're mostly found when they're late. So the number one recommendation now is follow symptoms really aggressively, especially red flags. There are lots of cases where they've said cases were delayed, diagnosis was delayed because we're not thinking about cancer in young patients. So that's the number one recommendation. Do not ignore symptoms. Investigate them thoroughly till they're resolved, or we at least have a sense of what's causing it. Blood and stool, like we have such low threshold now to get colonoscopy. The second point is really get a detailed family history. Could this patient have family history of cancer? Could this patient have family history of polyps? Could this patient have family history of other cancers? Could they be high risk? Could they have Lynch? They might start screening. They need screening early on. So this is the cohort we can find. I showed you 20% as from germline variants. Refer to genetic counseling if you suspect such high-risk families. African Americans should start screening by age 45. That should be done. And if you use American Cancer Society guidelines, you want to get your 45-year-old screened, you may be not able to get colonoscopy. FIT DNA, just to let you know, is approved for age 45 and above. So that's an FDA approved now for age 45, which can be considered. So when we talk about screening, we should know what are the modalities, because there are various options we can provide our patients. There's the big three categories are non-invasive. You have stool options, so guaiac fecal occult blood test or fecal immune chemical testing, or the multi-target, which is FIT DNA. Then you have semi-invasive, which is CT or MR colonography, and then you also have now capsule colonoscopy, basically swallowing a capsule and then looking at the colon, taking pictures, and then going after if you find something. And then we all are familiar with, of course, colonoscopy. Sigmoidoscopy is not a tool used really so much in the US. Like, you know, we can see right colon, we'll just scope you. So colonoscopy is the preferred if we go that route. So let's talk about them. How are they? What are the advantages and what's negative? So guaiac FOBT is an indirect measurement. It indirectly measures blood. It really measures peroxidase activity. It has to be done annually, and you need 3 stool cards. So you definitely need 3 and to make a decision. Certain diets, certain medication can make this give you a confounding result. So keep that in mind. But it's a cheap test, and you don't require any time off work and all the other issues with colonoscopy. You should only be using high sensitivity. I don't think even old sensitivity ones are even available, but high sensitivity FOBT is what should be used. Fecal immune chemical testing is better because it measures directly. It can do it with 1 stool card, although 2 is advised, but 1 you can do it. Again, yearly test. No diet or medication restriction, and no time off work needed. It's only $17, a $20 test. It's a very good test. Multi-target stool DNA, which is commercially called Cologuard, is approved. It's the good thing is you can do it every 3 years. It looks for blood, but you also look for some DNA markers. This can be done every 3 years. So how good are they? What should you pick up for your patient? Like I mentioned, guaic FOBT, if you go this route, sensitivity is up to 79%. You should only pick up high sensitivity one. It has good specificity. FIT is better, 92 up to 92% sensitive and good specificity. What about multi-target FIT DNA? Good sensitivity, but specificity is not as good as FIT. That basically means you're going to get some false positives, which will lead to some colonoscopy, which may not be required. So that's an issue. But again, you're doing it every 3 years. So it's possible that just balances it out. How are these for polyps? None of these tests are good for looking into polyps, even advanced adenomas. So more than 50% of polyps will be missed. FIT DNA, 42% sensitivity. FIT is around 30%. And they're really not good for serrated lesion. They're flat, they are difficult lesions. They can be easily missed using any of the stool tests. So that's the problem with stool tests, but they are not designed to look for polyps. They're really designed to look for cancer. And if it's anything positive, your patient must be aware. Sometimes patients don't know, but they have to get a colonoscopy. And not only a colonoscopy, but a timely colonoscopy. So there's data that if you delay it beyond 9 months, the stage you find cancer is much advanced, even 3 and 4. So the ideal time is do it as soon as possible. But 3 to 6 months is when you should be looking, getting them colonoscopy. So make sure you follow, of course. That's the big system issue. The other modalities are CT colonography, can be done every 5 years. Good for large polyps. It's semi-invasive, but I say there's no escape from bowel prep, so you still have to do bowel prep. For patients, it's expensive. It can add cost if you find some other things which may not need finding in some sense. So those are the issue. And the best way to do CT colonography is you do it in the morning, patient's prepped, you find something, get colonoscopy that afternoon. That may not be possible everywhere. So that's the ideal way to do it. You don't want to prep your patient twice. Colonoscopy, we're all aware, is a great tool because this is the only preventive tool. We can see polyps real time, remove real time. But colonoscopy is not without risk. It has it has problems. Sedation risk is not uncommon. Aspiration is not uncommon. But overall, the risks are still very low. Bleeding and colon perforation are the biggest risk we are worried about. Those risks have improved over time, and we have better tools to take care of at real time, even perforation. But still, when they happen, they're not pretty. It's not. This is the biggest disadvantage of colonoscopy. Plus, they're expensive. You also have to take time off work. You need a ride and all that. This is the only modality, although for high-risk cohort. You cannot do FIT and FIT DNA in high-risk cohort. This is the only modality which is recommended. I want to mention a blood test because patients do ask, do I have a blood test? Can I do a blood marker? There is a blood test approved called Septin9. It looks for methylated Septin9 DNA. This is not endorsed by any society to be used as an option unless your patient refuses everything else. So if your patient refuses colonoscopy, CT colonography, everything, then you can still offer this test. The reason it's not endorsed, the sensitivity is not good, of course for cancer, but also for polyps, and FIT DNA is better. The second kit is better, but specificity is not still good. So at this point, it's FDA approved for patients who are refusing other tests. So if your patient refuses, you still can, hopefully can find some cancer using this. So this is a marker which can be used if they're refusing everything. US Preventive Services Task Force say you can pick any tool. You can pick colonoscopy, you can pick FIT, you can pick CT colonography as your tool to offer. GI societies came out in a tier approach. So colonoscopy and FIT is tier 1. You can offer, if they refuse, you can offer CT colonography, FIT DNA. And tier 3 is the capsule colonoscopy. Now that's not available everywhere. It's also an expensive tool. It has some other issues, but that's why it's tier 3. What's not recommended from GI Society is Septin9. This is not truly recommended. But US Preventive Services Task Force, like I said, you can still do it. So where are we with screening rates? We're doing screening for almost 20 years now. Where are we? We achieved what we wanted to. So 2013, the study looked into the numbers. So in 2013, US average screening rate was 58%. And they calculated and said, let's bump this rate to 80% by 2018. What would happen? that showed that we'll save 200,000 lives from colon cancer, and roughly 277,000 new cases of colon cancer can be prevented over the next 20 years if we do this. This led to the initiative by American Cancer Society of 80% by 2018, which was really encouraging institute and practices to take up this goal to increase screening up to 80%. Now, this has changed into 80% in every community now because we are in 2020. But this is a goal which still carries on that we should achieve. We should achieve even higher, but 80% is the goal. So what happened? We're in 2020. Where are we? Nationally, we are at 66%. So we, of course, nationally have not achieved 80% as we expected. And since I'm on a Zoom call, I can't really ask my audience, but I always ask, what do you think your state is doing? And you can make a guess, but DC is better, 74% nationally better, but still not 80%. Certain places have achieved that. Kaiser Permanente in California has achieved 80%. So certain places which has a little bit more organized kind of approach to screening have achieved that, but not nationally. Nationally, we are all over the place. You can see here, gray is better and dark green is not. It's anywhere between 60 to 73%, 75%. And this is the latest data. The interesting thing is the lowest screening is between age 50 and 54, around 48%. 65 and above always did better in terms of screening. Uninsured, as expected, had lower screening rate, and 1 in 3 people are not getting screened. So that data has not changed. It's still there. So the barriers, this really comes down to primary care level, because in a GI clinic, I don't even see these patients. I don't see healthy patients in my clinic. So this really becomes a part of primary care life. Barriers, the biggest one still is lack of awareness and education, both from patient and provider. I wanted to highlight this study because it's a recent study in an urban setting. They asked 300 patients, 300 colon cancer patients, and asked, do you know of tools? What tools can prevent colon cancer? Only 20% knew about colonoscopy, and only roughly 13% knew about stool tests, saying there's still so much barrier and understanding. I've patients who I've seen, and they had no idea that they need screening, or at what age they start screening. So there's a lot of education needed. Also from provider level, like don't stop at the first modality, like follow. So be aware of all kind of modalities, and that's been a barrier. Access to care, not having a primary care is the biggest access to not having the proper care has shown as one of the main barriers. Affordability, of course, not having insurance or unable to afford it. And lack of interest is another interesting group. I have patients who are highly educated, knows about it, but still do not want to do it. And that's, I think, is still, we need motivation and education in this cohort to bring these people for screening. I'm part of the Utah Steering Committee for the same initiative, 80% by 2018. And this is an old chart, or what I really wanted to show you, this is from 2014, is this is a big problem in certain racial and ethnic groups. And this is nationally a problem. Now, Utah is not very diverse, but even in Utah, we have issues where Hispanics, Pacific Islanders, all that have lower screening rate. And this is kind of a national trend as well. Nationally, the screening rate, there is a disparity. And every state will have pockets doing better and not doing better. So be aware of what area and how we can improve it. So we always say, what's the best screening test? What can you pick up? Well, you can pick up what's available to you and what you can do. If CT colonography is not available, if you don't have that system in place, just do something what's available, but which can be followed up, which you can actually achieve. So how should you approach in your clinic? Number one is options. And give pros and cons. Tell your patient there's not only colonoscopy, we can do stool studies, and there are 3 different options. And these are the pros and cons. And I also talk to my primary care doctor. If they have questions, they can always ask us, especially for colonoscopy. Like they don't know what are the risk factors, like what could happen, what are the disadvantages, perforations, bleeding. So it's helpful for patients to know about all that. Offer second modality if the patient declines one. Follow periodically with the patient. Work with the patient and insurance. Also be aware of any free screening programs in your state. Some states have free screening for patients and make decisions based on indications, personal history, family history, try to find that high-risk cohort who may need genetics referral. So the last part of my talk is on genetics, and I wanted to focus on this part a little bit more because this is an evolving, expanding area in the world of pretty much any cancer, but colon cancer per se. And look at this pie again. This is from year 2000. Here, the number is roughly 5% or 6%. How has this pie changed over last many years? This is a study from 2017. 1,000 colon cancer. Again, we're looking at the same thing. How many of them will have a germline variant? If we do a multi-gene panel, so they had a 25-gene panel, and now we have more genes we can test for or look for associated. And 10% had germline mutations. So 10% of all colon cancer is now attributed to germline variants, which we can hopefully find. And the biggest chunk is still Lynch syndrome, 3%. And not to confuse it, but there's so many other pies have come up which are related to other genes which may or may not be playing a role, but they have a germline variant in the world of colon cancer. So I wanted to just talk about Lynch syndrome briefly, and why I wanted to talk about Lynch syndrome is this is getting more common. This is not an uncommon syndrome. The prevalence of Lynch is 1 in 300 to 1 in 400. That's pretty high. It's not a rare disease. And I always tell when I give talk that this is an important thing to remember. So if you look at your area, DC Metro has 6 million people. And if you do the math, you will find, at least from the math, like there could be around 15 to 20,000 patients with Lynch syndrome. And it's not that all Lynch syndrome patients will get cancer, but knowing is better because this can help with prevention. You can start screening early and that it helps their children and grandkids. So it's really important to identify Lynch syndrome. It's not uncommon. Other unique thing is it's not a polyposis condition. We cannot find it on colonoscopy. If I do a colonoscopy, I would not know this patient is Lynch because they can have 1 polyp, 2 polyps, 0 polyps, just cancer, nothing. It's not a polyposis condition. So the biggest way or the suspicion comes from family history, personal history. Even otherwise, even with all this, we can miss it. But those are a clue to find these patients. Colon cancer risk is very high, up to 60%. Risk of any Lynch cancer is up to 80%. So what is Lynch syndrome? We already kind of know about this, but this is mismatch repair gene defect due to the genes mentioned here. Colon and endometrial cancer have the highest risk, but other organs are also involved. And universal screening of all newly diagnosed colon cancer must be done at every institute. This is one of the best way to find Lynch cancers. All colon cancers should be tested irrespective of age for Lynch. And it depends on what gene they carry. Their risk varies. MLH1, MSH2 are the high risk, and then MSH6 and PMS2 has lower risk. And their recommendations also changes based on their risk. Compared to general population, they still have higher risk for colon cancer. So how do you find Lynch carriers? If patients have family history of Lynch syndrome, that's one way to know. Most of the time they have seen a genetic counselor. We have clinical criteria we can use, Amsterdam criteria, Bethesda criteria, not going into detail, but saying there are criteria which usually are used at a genetic counseling level. And what these are made of is personal family history of cancer. But they can still miss Lynch syndrome. Up to 68% of them did not find Lynch syndrome. So they are not foolproof. There's some good risk prediction models, PREM5, MMR Pro, and others. They are good risk prediction model where you, again, basically put in details of history of cancer and gives you a percentage. And then it says, can this patient qualify for genetic testing or not? That's one way to find it. Again, done at the genetic counsel level, mostly. Universal screening of all newly diagnosed colon cancer. This has to be done, should be done at every place. And maybe even endometrial cancer. At our institute, we test all endometrial cancer, irrespective of age for Lynch syndrome. And then this is the world of multi-gene panel. We are looking for other cancers and we're doing multi-gene. We're going to find atypical families who are not going to fit into this, but could have Lynch syndrome. So why we are worried about Lynch syndrome? They need intense cancer surveillance. Gene dependent, but starts colonoscopy early. 1 to 2 year surveillance. They also need stomach surveillance, duodenal, endometrial cancer, timing of surgery. If they're pancreas history cancer, then we need pancreas surveillance, but not for PMS2. urothelial cancer, skin cancer, saying that one person needs a ton of surveillance, which needs to be followed by someone who can actually keep an eye. And what I wanted to show you in one slide here is the cancer can creep up even if they have surveillance, but not as expected. So this first patient had colonoscopy in 2017, had colon cancer in 2020. At that time, he did not know he had Lynch. So it came in 3 years. The other patient, a young patient with ampullary cancer, had a normal endoscopy 2016, but had ampullary cancer. So they can creep up anytime if they're not getting surveilled. So I want to show you one slide based on what it means to know about family history, and even with just not knowing Lynch history, but the whole family keeping in perspective. So this is the 23-year-old with Lynch syndrome, no symptoms, normal scope. Start EGT at age 40. That's the recommendation now. We surveil every 3 to 5 years. How did her family look? So she was here, right here, arrow. Bunch of colon cancer as we expected. She also had a duodenal cancer in her family. So if you look at the guideline, does she even qualify for an upper endoscopy? Maybe, maybe not, but her aunt had duodenal cancer, so I decided to scope her. And I almost did not see this in my regular scope. I always, I put side viewer scope if I'm worried about ampulla. And because I knew her history, I had seen her in clinic, I was able to think about like, okay, let's look at the ampulla and drop the side viewer. That's how I found it. And she's a young girl with ampullary adenocarcinoma, just got her Whipple. So saying this, I was able to apply this treatment because I knew her story. I knew her family history, and I could go through using that. So what I'm getting at is we need a place for this high-risk cohort. So young onset cancer, like I mentioned, 20% will have germline variants. Half of them may have Lynch syndrome. You must, if you suspect suspicious family, refer to genetic counseling, highly useful, very, very useful to get genetic counseling on these patients. Multi-gene panel going to pick new genes and evolving data. Every few years, guidelines change, patients' family history change. We have no idea what new surveillance they need. So they basically need a dedicated clinic model, a team of experts to follow a patient registry. We have some clinics, my clinic is based on a similar model, where we see and what we deliver is really personalized and comprehensive cancer care, because it's very hard for one person to follow that, especially in primary care clinics. So you need some place where they can be referred to and followed. And these are young patients who we can really prevent cancer. So in summary, colon cancer remains a significant health burden with high mortality and morbidity. We should be detecting these cancers early and treating them early because this is a preventable cancer. We should understand what are colon polyps, what are the tools available, what we can deliver in the clinic level. Be aware of rising young onset colon cancer. How do you approach this young cohort? And also the role of genetics. High suspicious families refer to genetic counseling. We can really find this cohort if we can suspect early and prevent delay in diagnosis.